Great to have you all here. And I'm sorry this is a Zoom conference, an in-person conference, but it allows us to connect in different ways. But I know we're all looking forward to some meetings in which we get to interact with our peers and colleagues in the real in the future. So we're all looking forward to that. This is a topic I've been pretty passionate about for much of my career for various different reasons, and had a pretty extensive experience over the last 20 years. And so we'll kind of go right into this. And for some reason, my slides are not advancing. Okay, now they are. I have no, as Courtney mentioned, I have no relevant financial disclosures. And I've been at Stanford for not quite 3 years. Prior to that, I worked for about 19 years in Boise, Idaho. And I had a lot of clavicle fractures in Boise. I was an avid cyclist and a bike racer, took care of a number of cycling teams, and a ski patroller. Between myself and my PA, we saw anywhere from 100, sometimes as many as 150 clavicle fractures a year in a busy clavicle fracture practice. And that was 15 years of really focused on clavicle fractures. I treated over 300 operatively, so I got a chance a lot to see this, but saw a lot more than that, because we probably only operated on 20 to 25%, because I still think there's a very large role for non-operative treatment in clavicle fractures, for many fractures, and for some age groups, for sure. Adult population, a little different than the pediatric and adolescent population. This is a nice slide that basically outlines where these fractures occur. And I'm just going to draw a red box here. But if you look at clavicle fractures, you know, about 60 to 70% of these clavicle fractures occur at the age of about 25. And so this is really a common fracture. In fact, if you look under 10, 15 years of age, it's one of the more common fractures we see in kids. So this is a real problem. Especially in pediatric adolescents and young adults, especially those that are active. We know that the vast majority, maybe upwards of 80%, are in the mid-shaft location. Most of these in young athletes are displaced. So that's what we see, mid-shaft and displaced fractures. One of the things that we've learned in medicine over the last, century or so is that there's different types of research, and we classify this in terms of level of evidence, and higher levels of evidence are less likely to be incorrect. Lower levels of evidence are more likely to have bias. And I'll just kind of walk you through, how we think about some of these levels. In the 1960s, most of our orthopedic research and much of medical research was based on expert opinion, case series, or a retrospective look back, and sometimes a control group plus a case series. And these types of studies are sometimes that's all you have, but the challenge with that is there's more likely to have bias and errors in your conclusion. Over the last 20, 30 years, in particular last 15 years in orthopedics, there's this big transition from sort of retrospective case controls or retrospective case series to prospective data, and in some cases, randomized clinical trials. And if we have enough randomized clinical trials or prospective cohorts, you can group trials together and do sort of a systematic review or a meta-analysis, depending on the type of study you have. Kind of here's sort of the state of the art, 1950s, 1990s. Charles Neer and Carter Rowe wrote most of the landmark literature at that time, and they thought, for the most part, mid-shaft non-unions were pretty rare, under 1%. Malunions weren't discussed in terms of a fracture that heals with a bad position that patients aren't happy with. And they actually felt that if you did surgery, surgery was the leading cause of non-unions. And so they recommended against that, and they showed in the surgical literature, if you operate on it, you had about a 5%, 4% chance of causing a non-union. Well, that literature held for much of the last century, but there were some studies in the last 15, 20 years that have showed that actually fracture shortening, a lot of patients weren't very happy if they had more than 2-3 centimeters of shortening. Robeson did a really nice project looking at how do you predict who's going to have a non-union. And so they put together a large series of patients and then identified risk factors. And you can see that I'll show you a couple tables here, but these are some of the risk factors that they looked at in terms of, for example, age, gender, tobacco use, alcohol use, mental status. There's a number of things that actually contributed, and it helped us better understand who might get a fracture that doesn't heal. Some of the major variables, as you get older, unfortunately, the healing rate's poor. Females, for some reason, in some categories, have almost twice the rate of non-unions compared to males. We don't fully understand that. The degree of displacement is one of the best predictors, a widely displaced fracture, and a fracture that's comminuted in multiple pieces. So these are 4 very strong predictors. This is a table I use a lot in my practice. This article is now about 12 years old, but it's just as relevant today. But it allows you to pick ages, patterns of fractures, and sex of the patient. and to then give people information. So for example, if you're a 20-year-old, which is the age group that seems to heal the best, if you have a non-displaced, non-common fracture, you can see here, you have about a 99% chance of healing. If the fracture is displaced and common, if you're male, you've got about an 18% chance of it not healing. If you're female, you got about a 30% chance. So these numbers really help us guide patients and look at different types of fractures, age, sex. Once again, I call out that for some reason, women seem to have anywhere from 30 to 100% higher rates of non-union for comparable age groups and sexes, and we still don't fully understand that, but that's what the data shows. Now, this chart stops at age 20. We don't have near as much data on pediatric adolescent fractures, you know, the kind of 8 to 20-year-old patients. Ben Hayworth and the FACT Clavicle Fracture Study Group is looking into this, trying to collect more data. There's a growing number of randomized clinical trials, and I cite this study here by Dr. McKee out in the Canadian Orthopedic Trauma Society. This was about 14 years ago now, and it really changed the way we thought about fractures. And they actually compared head-to-head operative versus non-operative treatment for displaced mid-shaft clavicle fractures. This was an adult male group, 16 to 45. And they've had some interesting findings. If you had surgery, the functional outcome, at least in the shorter term, was better. And they had a lower rate of malunion and non-union with surgery. And so this is kind of a game changer, if you will, that made us start rethinking about 10, 15 years ago, maybe we should be operating on more clavicle fractures. Obremski, about 12 years ago, published a nice study about who does well with and without surgery. And their conclusion was probably at least 75% of patients do well without surgery, but there's about a quarter of them that don't do well, and especially those who shorten significantly. They have a non-union or a malunion. Those are the ones that don't do as well. And he also felt that if the shoulder really droops down, which sometimes happens with some clavicle fracture patterns, that was a predictor of patient dissatisfaction. We're still struggling. How do we know which ones won't do well and which ones will do well? Because if we only operate on the ones that wouldn't do well, that would be perfect. We don't want to operate on fractures that are going to do well without surgery. And we still struggle to predict that sometimes. Dr. McKee and others have actually looked at grouping large amounts of data, what they call a meta-analysis. In this case, it was 6 studies and 400 plus patients comparing operative and non-operative treatment. And they showed, once again, the non-union rate was higher in non-operative patients, lower in operative patients. So non-operative treatment overall had about a 15% non-union rate. It was about 1.4%, so about a 10-fold difference there. The symptomatic union rate was higher, meaning the fracture heals in an undesirable position the patient's not happy with from a functional or cosmetic point of view. And with surgery, that malunion rate's almost 0 because you get the fracture perfectly lined. But if you don't have surgery, there's about an 8 to 9% rate. The operative patients, they started therapy earlier because their fracture was stable, and they had early functional recovery in that group. But longer term outcomes, say 1-2 years or further, we're not sure if they do any better. So just some nice systematic review. The study's about 9-10 years old now. How about adolescents? Schultz looked at this and confining their group to the 10 to 18 years of patients and small series, only 16 patients. But they found that even fractures that were completely displaced and shortened and the mid shaft, for the most part, they found these patients did well. Most of these kids went back to sports, no complaints of malunions. Even in some cases where the fracture was displaced and shortened, they seemed to do quite well with non-operative treatment. So that might suggest that maybe younger patients do better without surgery compared to adults. If you look at complications from surgery, there are complications. This is a large review of administrative database, which has limitations, but you can track in many systems, you can track reoperation rates. And a couple things they found, about 25% of patients had surgery within 2 years. And most of it, probably 95%, was for hardware plate removal. The plates are kind of symptomatic for some people. Interestingly, 2.6% of them in this database were infected, which is unusual because I've actually never seen a clavicle fracture infection in my own practice and done them in 300. So 2.6% seemed a little bit higher than I would have expected. 2.6% non-union rate with surgery, which is a little bit higher than the other published literature at about 1.5%. Malunion at about 1%. Pneumothorax, which is a really interesting complication because you have to basically get into the thorax lining, the pleura, and cause a pneumothorax. And I've never seen this before, but it was described as a complication in this insurance database. And women, in particular, had higher rates of hardware removal and malunion. So women, for some reason, seem to struggle a little more. Vascular injury, it wasn't reported, but I know of a couple cases where I was in Idaho. I know of a couple vascular injuries during clavicle fracture surgery because the subclavian vessels are very, very close to the operative field. So while not reported in this database, it does happen. Now, Ben Hayworth, really interesting gentleman who's very committed to clavicle fractures and trauma and using data to guide how we make decisions. He was able to get together about 650 clavicle fractures from Boston Children's over a long period of time. And about 80+% were treated non-surgically, 18% were treated surgical. In their non-operative group, they had 1 out of 500 and some patients, so a very low rate, well under 1% rate of non-union. In the operative, they had about a little more than, or a little less than 1% rate in the operative cases. No infections in their series, but 13% of patients didn't like the plates or screws, so they had symptoms from that. And they did have a couple symptomatic malunions in the non-operative group. Just to summarize our findings, non-unions are very rare in this group. And in this case series, it appears that non-operative treatment gets very good results overall, including mid-shaft fractures like these. Now, can you get non-unions in adolescents? You can. In fact, Ben Hayworth and his non-operative study group also polled a number of surgeons, and I was part of this study here. It's about 15 different centers. We collected about a couple hundred years of surgical experience, and we're able to find about 25, 30 non-unions amongst a very large group of clavicle fracture surgeons. So they do occur, but they are quite rare. One thing we also know, though, what's happening is because the adult surgery approach is more operative now over the last 15 years, that has carried over into the adolescents. But we definitely know in adults they're getting a lot more surgery than were 15, 20 years ago. We also know that overall complication rates are quite low for both operative and non-operative treatment. And I think in a situation where you're not always sure what the right decision is, operative treatment may be appropriate, non-operative treatment may be appropriate, but it's not always clear. I think patient-centered decision-making, let the family and the patient really participate in the decision, is really critical. For adolescent fractures, another nice study, Andy Pennock and his group down at UC San Diego, they showed very good results of non-operative treatment, regardless of the sport the kids did, their age, and even some degree of clavicle fracture shortening. And they also noted that the functional difference side to side were basically, they didn't matter. There was no significant difference in pain, strength, shoulder range of motion, elbow range of motion. So once again, another study showing that young patients under the age of 18 may do better with non-operative treatment. This is a recommendation from the literature where people will kind of collect information and publish in what we call a level 5 review. Yang and Anders published this in 2017, and they commented that we are seeing a trend towards a lot more surgery in adult patients, and that appears to be impacting pediatric and adolescent patients as well. Whether we should be doing this is still not clear. We need more data in the pediatric adolescent world to really make this decision because we're not entirely clear yet if kids really need surgery, but it appears that they probably need less surgery than adults because the risk of non-union and malunion and symptoms associated with that are much less. This is another paper from 2019, basically came to the same conclusion. We don't have a clear consensus. If you talk to adult traumatologists, they tend to operate on pediatric adolescent clavicle fractures. If you talk to pediatric traumatologists, 10 years ago, there was more operative preference, if you will, amongst pediatric traumatologists, but over the last 5 to 10 years, in large part because of some of this data that Ben Hayworth and others have shown, you can see at many pediatric trauma centers, they're moving away from clavicle fracture operative treatment as a general rule. There's still reasons to do it, but less and less. And so it's interesting how the adult population indications for surgery are increasing, and in the pediatric population, they may be decreasing, although once again, we need better data to really make these decisions. Once again, symptomatic malunions, symptomatic non-unions are pretty rare in kids. So for displaced combinator fractures, these are the ones that we know have higher rates of non-union or malunion. A non-displaced fracture, almost never going to need a surgery, but displaced, multi-segmented combinator fractures, where are we right now? Well, we've got a lot more evidence about how we should make decisions for adult patients. The evidence suggests that at least for the first 6 to 12 months, the outcome, functional outcome, return to work, pain, return to sport, probably better for the first 6 to 12 months. We're not sure about long-term if you're better with surgery versus non-surgery, but in the short term for certain fracture patterns, you may be better off. The degree of shortening is still not known. Some studies suggest that 1 to 2 centimeters is sort of that threshold, but I don't know if we really have good data yet on is 2 centimeters acceptable, 3 centimeters is not. Obviously, if you're 6'5", 2 centimeters of shortening is not the same than if you're 5'2". You have much greater relative shortening of 2 centimeters in a 5'2" person versus a 6'5" person. So I don't know if we know the answer to that yet, and I think future research hopefully will help sort this out. We know that clavicle fracture treatment is safe in children. There are very low rates of complications. So there's many studies, at least 3 or 4 good studies now showing that low rates of complications. Van der Hoeven had one of the initial papers on this, Melman and a few others. But we also know that young patients, 18 and under, certainly 14, 15 and under, seem to have much better healing rates than adults. So non-union and malunion issues are not as much of a focus of ours. Once again, these problems are rare. You know, to do surgery to prevent a rare problem, you know, how many patients would you operate to prevent a problem? So if we operate on every clavicle fracture, you could argue we'd be operating on 75, 80% of our clavicle fractures that we're going to heal without needing surgery. And when you have complications with surgery, even if they're rare, that's a real problem. There's these concepts of number needed to treat, number needed to harm that look at those ratios. And we don't want to operate on patients that don't need surgery. So we still need more data to figure this out. Once again, as I said earlier, I'm a real believer in patient education, family education, and centering the decisions really in the family's hands. And I try to tell patients all the time, I'm not here to tell you what to do. I'm here to be your consultant and help you make a decision. But ultimately, I want you to own the decision and feel comfortable with it, especially in situations where we're not sure what the right thing is. And I think for clavicle fractures, it's not always clear, at least for some fracture patterns, you know, which should do better with surgery. If 100% of midshaft common fractures ended up with symptomatic malunions or non-unions, then it'd be easier to recommend surgery strongly. But since it's not 100%, it's a gray zone, and that's where patients' preferences, family preferences really come into play. Let's talk about what I think are pretty consistent surgical indications. Significant skin tinting. I don't know how well this shows up, but if you can see this, the bone is just starting to come through the skin here. This does happen occasionally with a sharp spike of bone. And so that's an indication in my mind, because an open fracture can become infected, which is a real problem. Once again, if the fracture shows up to you and bones come through the skin, getting it underneath the skin and avoiding the fracture infection is pretty important. Sometimes the trapezius, if the trapezius is caught between the fracture, which does happen sometimes, that's a guarantee, I think basically a guaranteed non-union generator. So that would be a reason to consider surgery. If someone has some neurovascular compromise, that's maybe a relative indication, but many surgeons think that you've got any type of brachial plexus injury, vascular injury, you need to stabilize the clavicle so you optimize the ideal outcome for the neurovascular injury. In multiple trauma settings where you're trying to mobilize patients early, fixing clavicles will allow people to mobilize early, which may have an impact on health, blood clots, atrophy, and other things. So in a multiple trauma setting, I think you can make an argument. Floating shoulder, when you have multiple fractures around the shoulder, proximal humerus, maybe a scapula, clavicle fracture, those types of more severe injuries, you can argue for that as well. One might argue maybe a relative indication, but high demand upper extremity sports. So if you throw something where your arm position really matters, a baseball, a football, a javelin, you serve a volleyball, things where your arm position, hand position matter for your accuracy, your velocity, your control. Some people think that if you've got significant shortening or displacement, that's going to alter your throwing mechanics. And once again, we don't have good data on that, but common sense would suggest that might be something to think about. Let's talk about some relative surgical indications. 1 to 2 centimeters of shortening or greater, perhaps. We don't have great data, but certainly something to think about. Once again, severe displacement or comminution. Sports, the athletes do get back sooner, and manual laborers will get back sooner. And a lot of the patients that I operate on in Idaho were manual laborers who wanted to make money, and some of them didn't have workman's comp covering the injury, and they might get back to full-time work 2 to 4 months earlier. And so they would choose surgery for that reason. Sports, cyclists, unfortunately, high rates of clavicle fractures in cyclists. I tell people all the time, if you're a cyclist, there are 2 types of cyclists, those who have broken their clavicle and those who will break their clavicle. It's very common when you fall off a bike. And they want to get back on their bike and train and race quickly. And if they don't, they may be out of the sport for 3-4 months or longer. Many will be back on their trainer within a week of surgery and competitive racing within 6 to 8 weeks. As I mentioned, the throwing athletes as well. Collision athletes, football and hockey come to mind. Those are the sports where I've seen a fair number of repeat flat fractures, fractures we thought were completely healed. And some people think collision athletes may have a higher risk of repeat fracture. I will say backpackers, if a backpacker who carries a strap, we had a lot of backpackers in Idaho, and smoke jumpers, and if they had a prominent bump on a clavicle fracture, right where their backpack strap rested, they were very unhappy. So backpackers might be a relative surgical indication. If any of you take care of motocross or motorcycle athletes, there's something called elite brace. It's a brace designed to prevent cervical spine injury if you crash and land on your helmet. And it's basically a brace that protects the cervical spine from a severe hyperextension or hyperflexion injury, but it rests on the clavicle. It's a very prominent area. And if there's a non-union or particularly a bump malunion, they're not happy with that. So that might be another group you think about it. And perhaps hand dominance. If you're right-handed or left-handed and you've got a fracture on your dominant side, that might influence your thinking as well. Last thing I'd throw in there is females. Females, we don't know why, but in many groups, there are anywhere from 30 to 100% higher rates of non-union for displaced combinated fractures. So that might be something to factor in as well. As I mentioned earlier about patient-centered decision-making, I think as we create better tools to educate our patients, we call them decision aids or patient decision aids. I have a decision tool that I give to patients, and it's written at 8th grade level education. So most people should be able to understand it, and it's graphic based, but it's a handout I give to patients. And for years, I would give this handout, and I'd say 70% or more patients would come to my clinic wanting to have surgery for the clavicle fracture. And after they read the handout, we get down to about 25%. And I would say under the age of 14 or 15, well under 5%. In fact, I can't remember operating on anyone under 10 or 12 in recent years, unless the fracture was open. So there's a picture of the handout. It's about a 4-page handout, and it's got a fair amount of information to really help them with the complex decision-making. And I also go through this table with the patients, and I try to draw their age, their sex, and their fracture pattern, and tell them, here is your risk of a non-union or a malunion. And then I go through kind of pros and cons. And this is sort of my pro and cons. Non-surgical on one side, surgical on the other side. And we just kind of walk through this and say, here's the plus and minus. So time for healing. It's going to take longer with non-surgical treatment. In adult males, it's about 28 weeks versus 16 weeks. So that's a almost 3-month difference. Shoulder function may have a little impact in the short term, not sure about long term. We know non-union risk is clearly lower with operative treatment. Cosmetic issues. You might have a bump where the fracture heals, but if you get it fixed, you won't have a bump, but you'll have a plate scar. And so is a bump worse than a scar? That's a personal decision. Infection risk, you're not going to get an infection with non-surgical treatment. The infection rate for surgical treatment, I tell people routinely for most of the procedures, it's about 1% overall. We take countermeasures to prevent infection, but there still is an infection risk. Very unlikely to have a nerve blood vessel injury with non-operative treatment. It does happen occasionally, and I have seen pneumothorax with clavicle fractures and probably some occult rib fractures as well. But it's quite rare. Surgical treatment, it's also rare. It does happen, it's reported in the literature. If you're an athlete or a worker, you will get back to cycling or running or sports quicker. You will get back to work if you have a manual labor job earlier. But if you have a non-labor job, it probably not much of a difference. If your fracture doesn't heal and you develop a non-union, you can still have surgery in the future. If you do have surgery, I tell people there's about 25% of patients seem to want the hard route in the future. So you might have second surgery as well. So we can talk a little bit about surgical techniques because there's different approaches, and this is evolving. Most fractures are currently treated with plates, at least in North America, but in Europe and other parts of the world, there's a fair amount of people who are using intramedullary rod devices. And people debate between 1 plate versus 2 plate, and we'll talk a little bit about that. Should the plate be on the top of the bone or on the front of the bone? Should you put a rod inside the bone or an intramedullary screw inside the bone instead of a plate and screw on the outside of the bone? Should you use a flexible rod or a rigid rod? And so these are kind of different things. And I don't need to give you too much detail. These are things surgeons argue about a little bit, but they have single large plates. They're quite strong. They're quite stiff. They're readily available in most trauma centers. There are special clavicle plates, and then you can even take some plates that aren't designed for clavicles, but can be bent and molded and configured to fit. These are big and they're strong, and some people think they may be too stiff. You don't want a plate that's too stiff because that may stress shield the bone. Dual plating, these are much smaller plates, much lower profile, and people tend not to feel them because they're a much less bulky piece of metal. Now, there are some advantages to that. Lower profile, they may have some advantage for large comminution areas. And in some cases, if you have 2 plates at 90 degrees to each other, so a superior plate and an anterior plate, that may give you some benefits to bending and torsional stress. They're not as stiff as the thicker plates, but not as stiff may actually be a good thing. Too stiff may stress shield the bone. One downside, though, is you do require more bone exposure and more stripping, and that may slow healing if you use the dual plating approach. Anterior plating, should you put the plates on the top or should you put them on the front? So put the plate right here where a strap would rub on it potentially, or if you put it on the front, the weight of the strap won't bother. So for people who wear backpacks, manual laborers who may carry work tool belts, leap braces, motorcycles, I think anterior plating certainly has its merits. Rods versus screws. I'm a big advocate for rods, and that's what I would want done on my own clavicle. My last 15 years, I was using more and more rods, but still probably 25 to 35% were rods, and 60 to 70% or so were plates and screws. You can't use rod for everything, but I like the rod because it's very low profile and almost never have to take them out because people don't feel them. They're basically inside the bone. And they also require a much smaller incision because you don't need to expose the whole clavicle plates and screws. So there's advantages and disadvantages, but rods have not caught on in much of North America compared to plates and screws. And that may change in the future, because for many long bones that we fix in orthopedics, plates were started first. And for example, the femur and the tibia, rods are used more often than plates and screws. There are still roles for plates and screws in the tibia and femur, but rods in many ways have some biomechanical advantages and smaller incisions and other issues. So still an evolving area. As I said earlier, this intramedullary screw device, which I'm particularly fond of, and I would like this on my own clavicle fracture. It's very low profile. You really don't strip the bone at all. And I think the healing rate with these is very quick. Very small incisions to put these in. And you don't disrupt the sensory nerves, because there are sensory nerves on the chest wall that when you put plates and screws in, you're going to disrupt some of those sensory nerves. And as I said earlier, it's not widely adopted yet. So I've got a number of case studies I'm just going to show you all now, but what I could do is we're about 25 minutes into it, and I didn't know if there's any chat questions or people want to raise their hands and ask questions. I could pause now for some questions, and then I've got 3 or 4 cases, and then time permitting, we can go through those cases.
Yeah, we have, Dr. Shea, we have 3 questions in the chat box right now. So I can read those off for you. If a person had a non-union fracture, what would the solution be for them?
Yeah, and I'll have one of these. I'll have a case that I'll show you. But a non-union, usually it depends a little bit on the position. If it's a good position alignment and it's not shortened or angled a lot, it's usually fairly straightforward to add some bone graft to non-union, freshen up the bone graft ends to create a better healing environment, and then stabilize it with plates and screws or with a rod. So that's the typical approach for a non-union, if they're symptomatic. I have seen patients who have non-unions and are not symptomatic. And I've actually got some case examples of some older patients who in their 70s, particularly I had a 70-year-old retired school teacher who was a tennis player, and she had a non-union on her non-dominant arm, and non-union was clear as day. She could feel it move, but she played tennis, it didn't hurt it. So, and she did one-handed backhand, so we never fixed it. So non-unions without pain would not be a reason to do surgery. So does that help, Courtney? Did we cover that answer adequately?
I think so. Next one would be, how can you tell if a patient has a soft tissue interposition?
Yeah, early on, the clavicle fracture is, there's a lot of soft tissue swelling around there, but you can usually, for most of us, if you just feel your clavicle, it's one of the easier bones to feel in the body. You start at the tip of your shoulder blade, your acromion, and you can walk, and you should be able to feel your clavicle all the way to your sternum, because the superior aspect of the clavicle is basically bare. It's periosteum, a little subcutaneous fat and skin. There's not a muscle area. As you go anteriorly, there is some pectus or pec muscle, but superiorly, you can feel the whole thing. Now, if you gently feel that area, and then you also feel the trapezius, the large muscle we have right here that extends from our neck to our scapula, you can feel sometimes that one end of the clavicle is basically pointing into the muscle, and that's going to be a non-union. And you may not be able to feel that early on just because there's a lot of swelling initially, but even early on, if you kind of palpate that, sometimes you'll feel in particular the lateral half of the clavicle, the edge is pushed posteriorly and incarcerated, basically punctured into the trapezius muscle, and you can feel it incarcerated there.
Okay. Next one, even if the table only shows down to 20 years old in terms of risk of malunion, is it reasonable to extrapolate and use the same table in dealing with the risk of malunion in the adolescent age range?
Great question, and I think it's not unreasonable. And if you look at the table, what happens is the 20 to 30 year age group has higher rates of union. The 30-year age group has lower rates of union. The 50 year, every year, the non-union risk as you get older seems to get higher. And so I think we might assume that the 20-year-old group maybe overestimates non-union a little bit, but I tend to treat, near skeletally mature or skeletally mature, kind of 14, 15 and above. I tend to treat them like young 20-year-old adults. And I tell the family, this is the best estimate we have. It's probably pretty close, but the healing rates may be even a little bit better, certainly under 14, 15. And I adjust that a little bit for male, female, because women, as you know, females, 12, 14-year-old females typically 2 years ahead on her skeletal maturity than the typical male. So I may make some sex adjustments, but I think it's a reasonable approximation, but it may overestimate the non-union malunion risk a little bit, just because if we extrapolate, it suggests that 10 to 20-year-old have lower rates of malunion and non-union if you follow the rest of that age curve. It's a really good question. And it's, I think what would be great is if we had 20 hospitals, children's hospitals over the next 10 years, reported data on their non-union rates for different fractures, different ages, different sexes, different fracture patterns, and we followed them to union. That's the kind of data we need to make these decisions.
Okay, we'll do two more. What about the impact of shortening in neck function and biomechanics?
Yeah, you know, I don't know as much about neck function because I tend to think of the neck's function kind of is defined as its relation to the axis of the central spine. But certainly biomechanics of the throwing arm. I think you could make a pretty good argument that for high-level throwing athletes or someone who's a really elite-level athlete, 2 centimeters of difference can make a difference. And so I think in the high-level person, it may matter. For the recreational athlete, the weekend warrior, I don't know if you can make a strong argument. You know, if you took a 45-year-old recreational softball player on the weekends and his or her clavicle healed with a little shortening of 1.5 centimeters, 2 centimeters, would they be able to notice they couldn't pitch as well or throw from, you know, left field to home plate as well? I don't know. You might, but I think in the more recreational athletes, it may not be as critical, but I don't think we really know. It's a great, once again, this is why I think it's such a patient-centered decision. It's because we don't really know. But there's really good questions, but we don't know if we have clear answers.
Okay, we'll do one more for now, and then we'll go into the case studies and answer more questions at the end. What should we have the patient do until they see an orthopedist? How soon should they be seen for a clavicle fracture?
Yeah, and a couple things. One, if there's normal pulses, you know, ulnar radial pulses, normal motor sensory function at the hand. It's kind of hard to sometimes assess the biceps and triceps because it hurts, but you can do a quick assessment of ulnar nerve, median nerve, ulnar nerve, and then radial nerve. And as long as all 3 of the nerve functions are normal at the hand and the vascular status is normal and the skin isn't tented, you know, sometimes you can see a little bit of displaced in the fractures, but if it looks like the skin is really tented by the fracture, I would get them in sooner. But if there's no skin tenting, no neurovascular issues, I think put them in a sling for comfort, ice packs, some ibuprofen, you know, something for some pain management. We're trying to use as little narcotics as possible, so I try not to use narcotics, and sling and ice packs for comfort, and get them into the orthopedic surgeon within a week or so, or sooner if it's available, but I think within a week or so is fine.
Real quick, Dr. Sheikh, do you mind defining what skin tenting means?
Yeah, I know what skin tenting is when I look at it, but when you can actually see the edge of the bone pretty clearly through the skin, the bone hasn't come through the skin, but it looks like it's pretty close. It's almost like a little tooth is about to erupt through the skin. I think that's a reason to get them in sooner, maybe even go to the emergency room. And I also keep an eye on fractures because I have seen fractures that weren't tented initially and then tented later on. And I have a personal experience with a kid who saw me. He was seen in the emergency room. They put a figure of 8 brace on. And he came to my clinic 8 days later, and he'd been in the figure 8 brace with his shoulders pulled back for 8 days. A 15-year-old kid, and I took the brace off, and the brace was tight enough that the bone was now about 1 centimeter of the clavicle was sticking through the skin underneath the brace, and it had just eroded through the skin, and it wasn't that way when he showed up. So I'm cautious. I don't use those figure 8 braces anymore, and there have been some studies comparing those to slings, and they don't seem to offer any more pain relief than a sling does. So the last question about emergent timing for coming to see a doctor or the emergency room is I would say, ask people if they're short of breath. And now sometimes they're going to be a little sore and they might be a little short of breath, but caution people that if they become short of breath, they could have a pneumothorax. And that's the reason to go to the emergency room and be seen sooner. And it may not develop right on, but I just caution patients about the possibility of a pneumothorax. The other thing is that with clavicle fractures, you know, the trauma of falling either directly on your chest wall or putting your arm out is sometimes people will have a rib fracture or two in addition to a clavicle fracture. And rib fractures can definitely cause a pneumothorax. So those are a couple little red flags to think about as well, that pneumothorax, shortness of breath issue.
Okay, great. So let's go through maybe 1 or 2 of your case studies, Dr. Shea, and then we'll open back up for more questions.
Okay, so let's see if we can move ahead. All right, so this is a picture I was sent yesterday by one of the adult hand surgeons. He said, Kevin, what do I do with this? This is a friend of the family. They're skiing in Teton Valley, Wyoming. And so their daughter's 8 years old, high-level skier, and she has this fracture. And this is what we call the Z fracture, because if you can think about it, it's got kind of a Z configuration. You know, it's got kind of a horizontal component, a vertical component, and another horizontal component. And these fractures are pretty notorious for not healing. It's a displaced fracture, and it's comminuted, and it's probably been high energy. In adults, this one, in most centers, is probably going to get surgery, unless the family really doesn't want surgery. 8-year-old child, I've seen plenty of these, and 8-year-old children heal beautifully without an operation. I've also seen plenty of adults operate on these fractures because they were convinced it wasn't going to heal. And they also healed fine with surgery, but I think they would have healed either way. They will perhaps have a little bit of a bump. An 8-year-old is going to remodel that bump significantly, and they'll have a little kind of bump that over a year or so, a year or 2 or 3 will smooth out. They may always notice a little bit of a bump, but it's so minor that unless it's an orthopedic surgeon who treats shoulder issues, most people would never notice it. And the functional outcome is probably going to be excellent with this. So that's an example. Like I said, this is a case I got yesterday from one of our hand surgeons here, asked me what I do. So this is a 13-year-old male. It's a real story. The patient of mine I took care of in Idaho had this fracture at age 13, these original films, and I asked how people would treat this. I think most people, based on what I've said today, 13-year-old male would probably treat this non-operatively. And that's how this was treated. I actually didn't treat him initially. I saw him several years later. 4 years later, he came into my clinic, and this is how he was seen. As I mentioned earlier on, that's how he was initially presented. This is fractured at age 13. And at age 17, he showed up in my clinic, and you can see this bump in his shoulder. And he's a soccer player, doesn't do overhand sports, but he had some pain and discomfort. Every time he hit the ground, his shoulder would hurt for a week or two. And you can see by the x-ray here, he's got a kind of a vertical V-shaped malunion, and he's got a non-union. You can see a clear gap between the ends of the clavicle fracture. And so this is one of those rare cases that happens. And here's just 2 close-up views. You can see he's got a kind of 2 oblique kind of oriented views showing the fracture in slightly different orientation, but clearly got a non-union, and he's painful. So this one was fairly easy. We ended up doing bone grafting and a plate fixation, and he healed fine. Took him about 4 months to completely heal, and was back to playing soccer. So that's one of those rare cases in a 13-year-old who goes on to a non-union. So this is a little older patient. This is a 20-year-old. You can see his proximal physis of the humerus is just about closed, but he's a motocross racer. Lots of motocross racers in Idaho. And this is another one of those Z fractures. You can see that horizontal medial piece, the vertical comminuted piece, and then the horizontal lateral piece. Once again, that Z configuration. These are notorious for not healing. And this is a racer, and he wears elite brace. And having a bump in the middle of his clavicle that probably won't remodel much at that age probably won't do as well. And so he was treated kind of traditional plate and screws to a good outcome and returned to racing. So here's another, this is actually one of my former physician partners who was 27 years old at the time, competitive bike racer. And this was his fracture. And we talked about options. It's completely displaced, a little bit comminuted. And I think we looked at his numbers, and he had about a 20% chance, 22% chance of a non-union or something like that in his age group. And so he chose to have surgery. And this was one where I fixed with an intramedullary device. And without my permission, I actually 3 weeks later after surgery, I actually bumped into him on a mountain bike trail. He was out bike racing. I wanted him to wait about 3 months, but that's how good he felt 3 weeks later. He's out mountain biking. The pins that you use, these rods, these different rods we mentioned, the one on the left is called a Rockwood pin. It's got a big nut on the end, which is a little bit prominent and sometimes bothers the edge of the shoulder a little bit. The device on your right is called an intramedullary screw, and this only sticks out about 4 or 5 millimeters from the back of the clavicle, and you can't even feel it. And so I actually think this device is a little bit better in terms of patient tolerance and not being bothered by that nut. But either of these is much less prominent than plates and screws on your clavicle. When you're picking plates and screws, there are some challenges. If you're going to operate on smaller patients, many of the plating systems we have are quite big. And so you got to be careful not to overwhelm the clavicle with this big 3.5 millimeter plate. And there are some smaller plating options available and smaller screw options. So I encourage someone, if they're going to have surgery or they're thinking about it, to ask their surgeon about, do you have, upsize and downsize plates and rods, just in case I've got a smaller clavicle, especially if you're female or younger, where your clavicle tends to be a little smaller. Once again, we talked about that adolescent skin tinting. Keep in mind that skin tinting is a real issue, and that'd be a reason to get them in sooner. I think once again, when I talk to surgeons, I say, make sure you got the plates you need and be readily prepared to use a smaller plating system. Distal 1/3 clavicle fractures tend to be very comminuted, and you need a very different plating system to work here because the traditional large plating systems won't work because the screws are too large for these small little fragments. In kids, the other thing you can keep in mind is the periosteum, the clavicle fracture will sometimes peel out of the periosteum. And in kids, that periosteum is so substantial that you can actually sew the plate back to the periosteum, and you don't have to do something to reconstruct the coronoid, the CC, the coronal-clavicular ligaments, which might require a reconstruction device in an older patient. You can actually use the thick periosteum of children to address these significant skin tinting issues. So some final research questions or future things to think about. Question I ask all the time, how many patients do we operate on to prevent one symptomatic non-union or malunion? We'd rather only operate on those who are going to have a symptomatic non-union or malunion, or they have a compelling reason to have early surgery. One of the ways we answer these questions, we do it with good quality randomized clinical trials, but these are hard to do. They're expensive, they're hard to generalize, and so randomized clinical trials are, as valuable as they are, they're really tough to get these done. And an alternative to that is our prospective cohorts, where you don't randomize patients, but you just take people as they come. And electronic medical records in many health systems are allowing us to collect data on patients and to do these prospective cohort studies now with a lot less energy, and we don't have to deal with all the challenges of randomization. The FACT Clavicle Study Group, it's a pediatric adolescent study group, is currently doing some of this work, and I hope they're going to give us more information in the future. I think we really want to identify those patient factors that should direct our patients, both children, adolescent, adults, into the right treatment path, because adolescents and adults may be similar, but pediatric adolescent patients are not the same as adults, and we need to modify and taper there and adjust their treatments accordingly based on their preferences and healing probabilities. I think it's very important that we collect our outcome data on how our patients are doing, and in particular our complication rates, because patients will, if you say, hey, I got a 20% infection rate, patients need to know that. We need to be frank and open with patients about complications. And these will also help with patient communication tools, which I think are critical for getting better outcome. And once again, Ben Hayworth, Michelle Caird, and others are looking at this with sports medicine societies and pediatric orthopedic societies to answer these questions. So that's really the last of my slides. I'd just like to thank Ben Hayworth and John Plowski, Ted Ganley, and Don Bay, who I've learned a lot about clavicle fracture treatment through the years and discussing cases with them. And I'll finish with one of my favorite, somewhat tongue-in-cheek quotes about orthopedics. Why treat something non-operatively when you can get the same result with surgery? And I say that jokingly because if we can get the same result without surgery, there's no risk. So we should avoid surgery where we can get the same desirable outcome. So that's it. So we have about 14 minutes for questions, or we can wrap up.
All right. So we got a whole bunch in, so bear with me, everyone, as we get through these questions. Dr. Shea, could you explain how a clavicle fracture can cause a pneumothorax?
The pneumothorax is the lining of the lung is right next to the clavicle and the ribs. And if you get a crack in a rib, the sharp edges of that rib can put a little tear into the lining of the thorax. And basically it's like popping a balloon. You now let air out versus air in. The rib is the rib and the clavicles are right next to the lung. And it doesn't take much displacement either during surgery or the sharp edge of the clavicle can actually pop that thorax lining and lead to a pneumothorax.
Okay. What is the exposure of rodding versus plating?
Courtney, let me point something out to you. You see my clavicle right here? This is my clavicle. The cupula of my lung is right above my clavicle. So believe it or not, my lung back here behind the clavicle is above my clavicle. That just tells you how close the lung itself is to the clavicle. The clavicle is actually remarkably close, and you have to be very aware of that when you're doing surgery. So, sorry, go ahead with your next question, Courtney.
That's okay. What is the exposure of rodding versus plating?
Yeah, the exposure of rodding, I'd say you can easily put a rod in with probably a 3 to 4 centimeter incision or less, depending on the type of fracture pattern. Whereas a plate, a plate might be 8, 10, 12, 14 centimeters, depending on the type of fracture. And so usually with a plate, you want 3 screws on either end of the fracture and sometimes 4. And so you have to have a plate long enough with 3 or 4 holes on one side of the fracture and 3 or 4 holes on the other side of the fracture. So that just requires a longer incision. Whereas the rod, because you put the rod in you don't have to expose the whole top or front of the clavicle to put plates and screws on. You can use a much smaller incision to place it inside.
Okay. Many/most pediatricians never send their clavicle fracture patients to orthopedics. So just to clarify, do you feel it reasonable if neurovascularly intact, no skin tenting, and since the malunion rate is so low, to place them in a sling, analgesic control, and follow up with the pediatrician only?
Absolutely. And you know, it depends a little bit on the pediatrician too. Some pediatricians are very comfortable with routine fracture care. They'll take care of, you know, distal radius fractures and ankle fractures and clavicle fractures. And some are not. And, you know, I'm happy to, I think most orthopedic surgeons are happy to see them if they're not, but a pediatrician, a family practitioner, internist, that they're comfortable with that. I think, as you've discussed, especially in pediatric patients, the risk of non-union and malunion is so low that if the pediatricians are comfortable, that's fine. I think sometimes families drive that referral to the orthopedic surgeon more than anything else. The families want to see a bone doctor for a bone injury, but not in all settings and not in all cases. So if pediatricians are comfortable with that, absolutely. I think that's perfectly appropriate.
Okay. How long do you advise to wear a sling for non-operative treatment? And then could you touch on when to get repeat x-rays?
Yeah. It depends a little bit on the fracture pattern and pain tolerance and everything else. But what's interesting about kids is I find that most kids within 3 weeks, if not 4 weeks, and occasionally 2 weeks, they feel comfortable enough to stop using the sling, at least for most of the day. I'll try to have patients start relatively soon. I'm going to try and back up from my screen and show this to you. I'll try to have patients within 2 or 3 weeks, if not 1 to 2 weeks. We call them Codman exercises or pendulum swings, where we just have them take the arm out of the sling and start moving the shoulder around. And that arc of motion can get bigger as their pain is tolerated. The other thing I'll do is I'll have them do what I call a spider walk, while I say, you know, start here and put your hand on the wall and walk your fingers up the wall, a little spider walk, and take your arm up as high as you can, go up to here. And then if they can go further, you know, they won't be able to do this in 1 or 2 weeks, but, you know, if they just start doing a little bit of motion and every day trying to go a little further, try to let them do a little bit of their home therapy along those lines. And typically 2, 3 to 4 weeks. I do counsel them, like for kids who go to school sometimes, that if you don't wear the sling at school, sometimes your friends will wrestle you to the ground and start playing with you. So sometimes I'll tell kids, hey, wear your sling for 2 months at school just to keep other kids from wrestling you to the ground. But usually within 2 or 3 weeks at home, you know, as they feel comfortable, we'll slowly wean them from the sling. I think most people done with their slings by 4 to 5 weeks.
Okay. How often does a clavicle fracture accompany with a dislocation in the AC joint?
Not very often, but it does happen. And in kids, as I mentioned that one case, I've had some AC separations in which in an adult, I would probably have to do some type of more invasive procedure because I can't sew back the corticoclavicular ligaments to the periosteum. In kids and adolescents, I've been amazed how I can just sew back this very thick, substantial periosteum, sew it back to the clavicle and back to the plate fixation, and not have to do a formal, you know, corticoclavicular ligament reconstruction that I might have to do in an adult. So they do happen. There are probably, you know, 5 to 10% of clavicle fractures have some type of AC joint injury. Some of them are not significant enough to need anything other than, you know, you're aware of it, and it might affect your rehab choice a little bit. But sometimes they actually do need a formal surgical reconstruction.
How can we discover the non-symptomatic non-union fracture?
You'd probably just pick it up on an incidental x-ray. And if it's non-symptomatic, you know, you may never pick it up, because if people, you know, if someone came and said, well, I had a clavicle fracture 2 years ago, and they're not having any pain, you probably wouldn't get an x-ray. And so non-symptomatic non-unions, they may be missed unless you get a chest x-ray or another injury evaluation for another reason later on. You can feel them. Sometimes, you know, if someone, you can feel them. You can actually, sometimes with non-unions, you can actually push on it and you can feel a little motion there. And sometimes the ends of the bone will be a little thicker, but you can actually feel a little bit of motion between those fractures.
All right. Can someone have an MRI with a rod or plate in place?
They can. You know, increasingly the MRIs, you always have to tell them, you might need to talk to radiologists ahead of time. The most reason you would get a shoulder MRI would be to look at a glenohumeral issue, rotator cuff issue, or an instability issue. And usually the plates and screws are far enough medially that they're not going to have too much of an artifact for that. But you always have to kind of go through let the MRI folks know. But most of the plate and screw systems, you can get MRIs, but they're going to introduce an artifact in some cases that make it a little bit harder to read. But since the plates typically will be far enough away from the shoulder, it shouldn't affect the visualization of the shoulder joint or the rotator cuff musculature.
All right. I think we might have talked about the sling wear, but I'm not sure if you touched on the repeat x-rays for the clavicle fracture. Could you discuss that a little bit further?
Yeah, it depends a little bit on the type of fracture and my concern about delayed union, non-union, but typically I'll bring it back in about 6 weeks for the first x-ray, and then maybe about 3 months, from the time of the first injury, about 6 weeks for the second injury, and then maybe 3 months or so for the second x-ray. In a lot of cases, they're well enough healed at 3 months that I don't need to see them again, but sometimes I may bring them back a little for another x-ray. It's 4.5 to 5 months. So depends a little bit on the fracture. And if you see really tremendous healing on the x-ray at 3 months, I'll tell the family it's about completely healed. I'd maybe do a little activity restriction for another 6 weeks or so, but I tell them I'm happy to see you back for another x-ray, but I'm pretty confident based on what I see, it's going to heal fine. And 6 weeks from now, you can do unlimited sports. And if you have any questions or issues, I'm happy to see you back, but I don't necessarily need to see you back.
All right. Do you mind explaining what a green stick fracture is and how that's treated?
Yeah, I'm looking around to see if I have something I can use to simulate a green stick. Basically what a green stick is, if you would take a fresh cut, moist piece of wood or a branch, the branch is still moist and somewhat soft. And if you try to snap it in two, like with a dry branch, which will just break in half, the green stick will kind of bend. You might have a little buckling of one part of the cortex and a little stretching of the other part of the cortex, but it won't completely separate and break apart. So that's sort of a green stick fracture. And I do see a fair amount of sort of green stick bend fractures in kids that tend to heal great. In fact, those ones usually at 6-8 weeks, they're completely healed and back and doing whatever they want. So that's a very fast healing fracture if you see it.
Can we give electrotherapy like IFT over plates?
Great question. I don't know the answer to that. I don't know if there's any recommendations about plates and how they might interact with surface therapy. So I checked with the manufacturers of those devices. They've probably got some recommendations.
All right. Is there a way to prevent clavicle fractures in cycling?
Yeah, become a jogger. Yeah, it's a good question. One thing a lot of professional race teams and even serious recreational cyclists is they will practice crashing, where they kind of learn how to roll and relax when they're crashing. And that may help to some degree, teaching people to roll hard versus roll soft. If you put your arm out like that, which is good for protecting you, you may be more likely to break it. Whereas if you tend to tuck and roll, but the reason people put their arm out is it tends to protect your head. We put our arms out to protect our head from an injury. And I'd almost argue I'd rather have a clavicle fracture than a head injury. So if I've got to sacrifice my clavicle or my forearm to protect what's in my cranium, that may be better. But yeah, I don't know if there is anything. The downhill mountain bikers will wear pads, almost like a very low profile shoulder pad. But yeah, I learn to become a really good cyclist and maybe really work on your bike handling skills to lower your risk of a fracture so you're less likely to crash.
All right, this will be our last one. Are the plates permanently placed or can they be removed?
Yeah, they can be removed. And in about 25% of patients, because there's not much covering this, when the swan goes down, you really feel the plate. And so about 25% of patients prefer to have them removed, but many patients leave them in. And if they're in more than 2, 3, 5 years, sometimes they get so ingrained into the bone, it gets a little harder to get them out. And sometimes the screws will strip when you get them out, so it's a little hard to remove things. So if you're going to remove them, probably good to do it in the first 2 or 3 years because it may be more difficult later on. But yeah, they can be removed. Their screws are designed to go in and out.
All right. Actually, one last one. And I think you might have touched on this, Dr. Shea, but maybe just a little more clarification. As far as when is it allowed to return to sport activity after the fracture in case of non-operative treatment?
Yeah, and I think that 3-month x-ray, except for the green stick fracture, but that the 6-week x-ray of the green stick fracture, it's probably gonna be healed enough that by 6 to 8 weeks, they're ready to go back. For the more complex displaced fractures or common fractures, that 3-month x-ray will help me decide that. It's a bit of a judgment call, but if there's a significant amount of callus surrounding the fracture, I'll usually counsel them that you probably need another 6 weeks or so, maybe 8 weeks to get back to unlimited contact sports. If it's a lower risk contact sport or a non-contact sport, getting back sooner, I think is fine. But I think sport influences as well. Hockey, football, lacrosse to some degree, soccer to some degree, maybe even basketball, but the higher collision, higher contact sports, I may make them go back a little later, but I'll let them work on training and conditioning and skill development, usually at 2 months or so they don't decondition too much.
Excellent. All right, well, I think we're right about time. Thank you so much, Dr. Shea, for answering all those questions and presenting on clavicle fractures.